Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the HEMONC podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we round out our ITP series, this time talking about some of the more nuanced cases, patients that don't really respond, and some really tough, complicated cases that we tend to see on the consult side every now and then.
Really excited to get into this one. We're going to really go through all of the things we've talked about before, but in just practical case format. And this is classical benign hematology, whatever we want to call it these days.
Yeah, let's do it.
All right, guys, let's roll that show. The last couple of episodes, guys, we've had an awesome conversation of ITP, a really heterogeneous disease, one that doesn't have a lot of good sequencing guidelines. And so this is not infrequent that patients get referred to our clinics for guidance on how to manage these patients. And so really having a nice approach to ITP management will go a long way for you and your patients. I think that in this episode, it'd be great to talk about those cases that we get every now and then, the people that just don't respond to the therapies that we talked about in the last couple of episodes, and really setting our listeners up for success about how to approach these cases.
Before we get into the cases, we have to do our banter real quick, and I have to say this: Ronak is somehow still wearing the medal. He put it back on. I have no idea. From the last recording to this recording, Ronak ran a 5K. That's it. It's a Gen Z phenomenon, Ronak. This is not a millennial thing to do.
I think what happened is that it just never came off. I feel like he probably has slept and bathed in this metal, which he should. It is his right.
It is my whole personality. Anyone that's met me in the last week in between these recordings knows that this is all I can talk about. So it is what it is. It used to be all I could talk about was CrossFit, but now I'm just a 5K guy.
Sidebar, over the past 6 weeks, I've actually run 100 miles, actually a little over. So just putting that out there.
And in the past 5 weeks, I've run 0 miles. So just throwing it out there. I've just been taking care of a baby.
Dan, I'll send you a medal in the mail just for that accolade. Or you could take this one.
Where's my diaper medal, right?
We'll get you a diaper medal.
Big golden diaper.
All right. So I'm going to kick us off today. And let's just go through some cases, honestly, because I think that's really how we're going to structure the discussion. And let's go with our first case, and I think this is something that we see frequently. So let's say you have a 24-year-old, otherwise healthy female patient who is diagnosed with ITP. Her baseline platelet count remains consistently in the 80s. She recently became pregnant and is in her first trimester. As part of her prenatal visits with OB, she gets a CBC, and her platelets are now 34. What do you do now? So this is pregnancy ITP, and now we have a pregnant patient who's in her first trimester.
So thrombocytopenia in pregnancy in itself could be a whole episode, but a quick note is that the most common cause of thrombocytopenia in the first trimester is ITP. In the second trimester, it's the most common cause for patients with a platelet count of less than 100. And in the third trimester, there's a lot of other causes. There's a really nice image that we'll include in our show notes from the ASH How I Treat guidelines that really lays this out. But it's important as we make our differential diagnosis, especially since ITP is a diagnosis of exclusion.
So Ronak, I want to recap that because that's so important to echo what you just said. First trimester, it's probably ITP. Second trimester, if you're less than 100, probably ITP. Third trimester, think of all the other stuff.
Yeah, you said it well, Vivek. So the guidelines typically recommend close observation and not treating in the first 8 months of pregnancy unless the platelet count is less than 20 or there's bleeding. In the weeks leading up to the expected due date, all of this changes. It varies by institution, but in general, it's important that patients maintain platelet counts greater than 70 in order to get an epidural, especially in preparation for the delivery. And if no epidural is desired, most of OBs will want platelets over 50 just to help with the complications of bleeding. So let's say treatment is needed. The first thing that we want to do is consider IVIG. There's different treatment options here in terms of dosages. You can do 0.4 grams per kilogram for 5 days, or you can do 1 gram per kilogram for 2 days, or you can even give 2 grams per kilogram once. And this can be considered every few weeks to really maintain that platelet count in that safe range that you need for your patient. If steroids are needed, remember that prednisone is preferred over dexamethasone, and that's because dexamethasone can cross the placenta and cause fetal birth defects. Steroids are typically, though, reserved for patients until the 35th or 36th week mark just to try to limit the maternal side effects. And if patients remain refractory and their platelets remain less than 20, options can include things like rituximab, azathioprine, or cyclosporin, but know that these drugs do take a while to work. TPO-RAs do cross the placenta. There are limited data about their use in pregnancy, but certainly there are case reports where patients have been treated with this and have been successful. Splenectomy is rarely used in this situation, but technically still remains an option. So a lot of different ways that this can go. I think the biggest takeaway is you need to monitor your patient's platelets very, very closely and start coming up with the plan as to what you're going to do in the event that those platelets drop, because you really don't want to set your patient up for failure leading up to their delivery date.
Yeah, and I think it's important to go through what you just went with your patient too, just to let them know, hey, we're going to be watching you closely as we give you some of these therapies, and we may have to repeat some of these therapies during your pregnancy. And so it's just watching very closely for bleeding, complications, and trying to prevent those and staying on top of it. So I think that was a great review. And remember, listeners, check out our other episodes if you want to know how do I just work up a patient in general. We're not going to rehash all of those points. We're just going to talk about some more challenging cases in today's episode. So let's move on to our next case. So let's say we have a patient who's on anticoagulation with ITP. So we have a 61-year-old male with a medical history of AFib on apixaban, hypertension, hyperlipidemia, who presents with new onset petechiae and increased gum bleeding. Platelet count on presentation is 12, and the other cell lines are normal. Workup after we excluded all of the other scary things, did a smear, looked for pseudothrombocytopenia as well, no platelet clumping, no new medications, no recent infections, no recent viral infections, really did a broad workup. All of that came back unremarkable, so we have our diagnosis of exclusion of ITP. The apixaban is held. He started on pulse dose dexamethasone 40 milligrams for 4 days and IVIG rescue therapy because his platelets were 12 and he was on anticoagulation, so it's a concerning thing. 1 gram per kilogram again for 2 days. And on hospital day 5, he responded very beautifully. His platelet count's 43. And the primary team asks about platelet goals with anticoagulation. How do you approach this situation?
Yeah, I have a couple of different thresholds for anticoagulation and platelets. I generally think that below a platelet count of 30,000, I'm not really messing with any form of anticoagulation. Oftentimes in between 30 and 50,000, I'm okay with like a preventive dose, prophylactic dose blood thinner. But if I want somebody on therapeutic anticoagulation, I really prefer that their platelet count be over 50,000. Certainly, case by case, if someone has a really strong indication for anticoagulation and their platelet count's been hovering at like 48,000, 51,000, 49,000, you can consider keeping them on therapeutic. But in the case of something like atrial fibrillation, where we're thinking about stroke risk integrated over the course of a year and just not as strong of an indication to keep somebody consistently on that blood thinner, 50,000 or bust, really, for me. Sometimes we'll arbitrarily set a little higher target, say maybe 70,000, just to know that we have that buffer if there are fluctuations in their platelet count for one of these lower risk indications for anticoagulation. And you also have to think about somebody's bleeding risk, right? If they have a history of having bleed episodes or prone to falls, prior GI bleeding, some of those high-risk situations, you may consider that sort of higher target, again, to give yourself a little bit of a buffer there.
And the risk-benefit calculation is important. Dan, I want to switch up the case a little bit. We have a 61-year-old patient. They had chronic ITP. So this is a patient who we know had ITP, had chronic ITP. They had initially gotten Dex, didn't work. Got some steroids with prednisone after the Dex with a longer taper, didn't work. Got some rituximab, didn't work. And they were on, most recently, altrombopag for that TPO mimetic, had good platelet control, but then developed a PE. And at the time, their platelets were over 400. We know this can happen with our TPO mimetics. We said in our last episode, about 6% of patients on TPO mimetics can get a thrombosis. So now this patient had a PE, and they had held their altrombopag in the setting of that PE, and they were started on Eliquis, and they come to see you in hematology clinic 1 month later. They've been off their L-Tropopag, and now their platelet count is 12. How do you approach that situation with a pretty fresh clot? And now they have recurrent ITP. They presumably may have developed that clot maybe because they had too high of a platelets on their TPO-mimetic. Maybe it was from the TPO-mimetic. What are you going to do in this situation?
It's tough. You really are in an unfortunate situation where you have somebody who clearly is in a prothrombotic milieu with their fresh clot, and at the same time, really low platelets. So the safety of therapeutic anticoagulation in someone who has a platelet count of 12 related to ITP, as opposed to something like HIT, which we know is a whole different thing, we're not really going to want to therapeutically anticoagulate that person. I do want their platelets to come up fast, though. So this person's getting admitted to the hospital. They're going to get an IVIG and DEX to try and pop them up quickly so that I can continue therapeutic anticoagulation. The apixaban's off the table for now. We're going to get them on a heparin infusion. And sort of once things stabilize out, we can consider getting them back on to their oral anticoagulant. In this type of patient, I would probably favor getting them back on a TPO-mimetic, maybe at a lower dose, just see if we can't split the difference, get them down into a safer, more normal physiologic platelet count range. You know, it's unfortunate. Sometimes when you see those platelet counts go high on a TPO-mimetic, that means that they actually can fly without them, but this guy clearly couldn't. And, you know, if the patient's not comfortable with that, or if, you know, this thrombosis had happened at a really normal platelet count and not an elevated one, you might consider just introducing a next line of therapy, one of your fostamatinib, rilzabrutinib options.
Yeah, I think that's really practical, and I just want to highlight for our listeners, when you're starting L-Tropopag, we often will start at a dose of 25 milligrams. Particularly for those of Asian descent, they metabolize the drug differently. You're not going to up-titrate that patient for at least a month trial on that lower dose. Many of our patients will need about 50 milligrams to really get a good platelet response, and you'll up-titrate the dose every 2 weeks as in the package insert. Sometimes I do weekly. If I don't see a good platelet response after about a week, I might go up to that 50 milligrams. We try not to go above 75 milligrams when it comes to L-Tropopag. For avatrombopag, that other agent, and we talked about switch therapy, and there'll be another case to talk about that, we often start at a 20 milligram dose, potentially up-titrating up to a 40 milligram dose. So it's important to know, maybe this patient was on 50 milligrams, maybe you go down to 25 milligrams. You could always switch to avatrombopag. That's an option. And also just know that chronic ITP can cause thrombosis. We don't know if it's a mechanism because of the TPO-mimetic or because of the underlying disease. And I think that's another important thing to flesh out, and just know that at the end of the day, you got to anticoagulate that person who has an acute thrombosis. You don't want that PE to extend, right? That's the purpose of this anticoagulation. So let's move on to another case, and this is a patient with a life-threatening bleed. So Ronak, let's say we have an 83-year-old male with past medical history of diabetes, coronary disease, and hypertension. He comes to the emergency department with new onset headaches, got a head CT that revealed a subdural hematoma. CBC reveals platelet counts of 15. His prior baseline, we always check for that baseline, was 190, and that was about 2 years ago. His workup, after we ruled out all of the other things, we thought about looking at the smear, clumping, prior infections, new medications, is highly concerning for ITP. What do we do from here?
This is a really tough situation, and probably one, though, that we will get at least once or twice each year, so just something to be aware of. In this case, we have to just take a multi-pronged approach. A lot of what we've talked about up to this point is being stepwise, introducing one agent at a time, seeing what works. In this case, your patient is bleeding. And so really the general consensus, the expert opinions on this is just that you got to throw combination therapy at them. Backbone is definitely going to be high-dose steroids, that dexamethasone. You can even give that IV. Some physicians will even recommend giving IV methylprednisolone at 1 gram in your patients. So super high-dose steroids there. You're also going to introduce IVIG to this patient, likely at that 1 gram per kilogram for 2 days at the very least. And this is one of the rare instances where platelet transfusions may be needed. I know a lot of us learn about not giving platelet transfusions in ITP because you're sort of fueling the fire per se, but the reality is that you need to do something to temporize this bleeding. Many of these platelets are likely going to be consumed. They're not going to stick around very long. They may need several transfusions per day, but it's the best thing that we have to try to remedy the situation. And then while all of that is working, we also want to start thinking about what other agents we can add in. This is where I think there's a really nice role for TPO-RAs to be introduced, and that's just because of their faster onset of action, that 1 to 2 weeks that we talked about as opposed to some of the other therapies. So again, what you're doing is you're trying to get some temporizing of the bleeding with the transfusions. The steroids will work pretty quickly. The IVIG is going to work pretty quickly. And then what you're doing for the long haul, trying to get them out of this danger zone, is let that TPO-RA kick in and allow for more of a sustained response. And there's a really nice graphic from an ASH publication that we'll link in our show notes to really hit this point home.
I'm so glad you mentioned that with the platelet transfusions, because this is so key, right? We don't expect platelet transfusions to have a major impact on the platelet count, but you also don't withhold them from somebody who is having significant bleeding. We know that those platelets, in addition to being consumed by the immune system, are probably going out and doing their job somewhere. And so, yeah, just really important to keep that in mind. We're not going to give them empirically, but if someone's bleeding, get the transfusion going.
And I think it's always true when a patient's sick in front of you, what you learn in internal medicine residency, load the boat. Just give that patient everything, right? At this point, you're going to give this patient literally everything. Throw the kitchen sink, right? You don't have room for error here. You don't have the ability to wait and say, oh, let's just see if the steroids work. You're going to throw everything at that patient to get them out of the danger zone. So I think this is a really good case. That graph, check out our show notes, is really interesting when you look at what happens is that you give the patient platelets and you kind of see them go up and down. It's very, very telling, that figure that Dr. Arnold has created. It's a really good visual representation of what we're doing for our patients. So let's go for another case. This is a case that I saw on consults recently. So let's say that we have a 64-year-old male who had a prior history of squamous cell carcinoma and the oropharynx, got definitive chemotherapy and radiation. That was about 3 years ago. And now he's coming in with petechial rash, gum bleeding, and a platelet count less than 10. And we've ruled out everything else, and we think this patient has ITP. So we got what we normally do. We gave him some IVIG. We gave him some dexamethasone, 40 for 4 days, and he had no response. And that was 3 weeks before I came on service. After that, he gets started on 1 mg per kg of prednisone and also had an addition of rituximab thrown at him. Still didn't respond to those therapies. His platelet count has been less than 10 this whole time. What are you all thinking about in this situation? So it's a patient who had multiple therapies. This happens. We come on service, we see this patient, they've been in the hospital for 3 weeks. And, how are you going to approach this patient? What additional workup are you thinking about in your head?
Yeah, unfortunately, like you said, ITP is a diagnosis of exclusion, right? So you do have to think about other more dangerous causes for low platelet count. Not to say ITP isn't dangerous. It can be life-threatening and even life-ending. But there are things that we have to think about in somebody who's had exposure to chemoradiation, namely MDS, myelodysplasia, so direct injury to the bone marrow from the treatments that they've gotten for their head and neck cancer. You also have to think about the possibility of metastatic recurrence. Maybe this person had a recurrence of their head and neck cancer and it's invaded the bone marrow. So like any patient with thrombocytopenia, you're going to want to look at the smear. You're coming on with fresh eyes. I always like to try and take that case from the ground up. Have a look at the smear, see if you're seeing any signs of a myelophysic process, something like your teardrop cells, leukoerythroplastic smear, something like that, or any signs of dysplasia, large, funny-looking platelets, funny-looking white cells. But ultimately, this is the kind of case that may warrant a bone marrow biopsy. You're going to look for some of those MDS-associated mutations or just visual cues that there's been a dysplastic event or evidence of metastatic cancer. Also, depending on how recent their therapy was, you can think about the direct toxic effects on the bone marrow, right? So marrow suppression from recent radiation or recent chemotherapy. These are reasons why you may not see that elevation in platelet count with a standard therapy. Sometimes, depending on what the platelet count is, if you can actually have that denominator, this could be a setting where an immature platelet fraction might be helpful, or you can see, are they producing a lot of new platelets and they're just getting consumed, or is this someone who is really seeing hypoproduction?
And Dan, I think that this really does set the stage, though, just to briefly mention that every now and then we do have patients that we claim as having refractory ITP. And so since we don't use splenectomies as often, which was part of the old definition, we currently define refractory ITP as patients who lack a response to 2 or more rescue therapies and or disease-modifying treatments with or without bleeding manifestations. And, again, we have a good review article that we'll include in our show notes, but briefly, About 50% of refractory ITP is really primary ITP, just refractory. But then the other 50% is all the other things. So one of these certainly being, the possibility of MDS or something related to prior exposures. But also there can be secondary ITP. So something else systemic that is causing these patients to develop an ITP-like picture, but it is not quite the same as the run-of-the-mill ITP that we're discussing here. They may be another inherited form of thrombocytopenia. So about 15% of patients will have an inherited form of thrombocytopenia, and that's why they're not responding. 10% will have bone marrow failure syndromes. We mentioned 10% for MDS, and then about 5% may be drug-induced thrombocytopenia. So it's really important that when these patients aren't responding, as Vivek said, especially after all these therapeutic challenges, you have to broaden your differential and say, could this patient really have something else? And this is the perfect scenario where a bone marrow biopsy may be indicated for your patient.
And I'll go on to say that if your patient's not responding to frontline ITP therapy, do a bone marrow biopsy and get a full body CT scan. Because you're not going to be wrong in doing that, because you may have a lymphoma. You may have an underlying bone marrow issue. It's not unreasonable to do those things. I'm not saying you have to do that for every patient, but it's a reasonable thing to think about, particularly if a patient had other B symptoms when you're thinking about a malignancy. So very clear here, this patient got a bone marrow biopsy. Turns out that this patient actually had increased blasts and MDS, which, was related to the prior chemotherapy and radiation exposure. So it's important to always have that on the top mind of your differential diagnosis, that Rona broke down the percentages there. The age of the patient matters when you think, is this inherited? I mean, well, if you have this older patient who got chemo radiation, maybe they're in that 10% bucket of an MDS or the 10% bucket of a secondary ITP to something else. You're going to review all of their medications and see what's going on with that patient. So I thought that was a good case. I'm going to give you all another case. This is going to be a refractory ITP case. So let's say that the same patient, we did the bone marrow biopsy, no cancer. We did a CT scan, no cancer. They've now seen, inpatient, 2 courses of steroids, IVIG, and now you're asking your PNT committee to get some of those TPO mimetics approved. And so you do, and you gave this patient Nplate or romiplastin, and you did that for 3 weeks and still no response. The patient's been in the hospital now for about 6-7 weeks. They haven't responded to this TPO mimetic. What are you guys thinking about doing here?
Well, it depends a little bit on what they're up for. At this point, we can think about a couple of different things. In the back of my mind, I am thinking about the surgical option. I'm thinking a little bit about splenectomy, but I'm going to hold off on that for right now. We do tend to think right now, current recommendations are you try and maximize that medical therapy for at least a year. You're not going to keep them in a hospital for a year, but you tend to reserve splenectomy for folks who've had chronic ITP dealing with it for a year or greater before you go there. But certainly, as we know, switching TPO mimetics can sometimes be effective. If there are options that are not on formulary for your hospital, you can sometimes still get them by making it an outpatient prescription and having a family member bring it to the hospital and just bringing it as a non-formulary drug. And so that could be something we consider here. But again, all of these things take time, right? It's a stepwise process. Another thing, like you mentioned before, reviewing the medications. People in the hospital tend to get exposed to vancomycin. It just seems to happen. And so this is one of the things that you can think about. Vancomycin causes a really refractory drug-induced ITP. And there are a lot of other agents out there that can do it too. And so if there's been a drug introduced at some point in this person's experience, they may have a component of that drug-induced ITP as well. Ultimately, if you exhaust all those options, you might end up looking at something like a splenectomy. And it can be a really good therapy for folks. It's one of the things that it can provide a really sustained duration response. The median duration was about 81 months in a 2018 systemic review looking at multiple ITP therapies. So definitely a sustained remission, especially compared to some of our other options. But it comes with those risks of increased infection risk from encapsulated bacteria. You need to give them their splenectomy vaccines, pneumococcus, meningococcus, H. flu, and prophylactic antibiotics if you don't have that 2-week buffer time to let those take effect before the spleen comes out. You also have to provide thromboprophylaxis for at least a couple weeks post-operatively. There's also, the spleen's a crafty little organ, and if the spleen is taken out and they have an initial remission and then a quick relapse, you have to think about something like a splenule that might have enlarged. About 10% of folks in general population have a splenule, or splenosis. If there was, some splenic tissue could seed the peritoneum and basically little spleens can pop up. It's a weird thing, but the spleen can do that. And so sometimes you may even need to do something like a heat-killed red cell scan to try and find ectopic splenic tissue. Lastly, and you could also consider the T cell axis of suppression. Probably want to think about that even before splenectomy. But it's one of these things where if the B cell therapies aren't doing it, there's a chance that there could be just a major T cell component as well. And so that's where mycophenolate, cyclosporin kind of come in. Mycophenolate is probably the best studied, has the most data behind it. So that's the one we tend to reach for first. And again, azathioprine has kind of fallen out of favor. Just the risk benefit seems to not really favor doing it. But those other two, mycophenolate, cyclosporin, could be valuable options in that case.
And so this patient ended up going for that T cell suppression route before we went for the splenectomy, tried mycophenolate, and the doses that we're looking at is 1 gram to 2 grams per day when we think about the mycophenolate dosing for these patients. Didn't work. Trialed on cyclosporin after that. This is hospital week 9. This is a true case. And the cyclosporin shooting for a trough 1 to 200 did the trick. And the patient's platelets had responded. The patient finally got out of the hospital. This is a true case. You'll run into these cases eventually, so we want to highlight a couple things here. These refractory cases, remember to exclude secondary causes. Bone marrow biopsy, consider maybe a secondary ITP from a lymphomatous process. After you've done those things, then you're going to think about either splenectomy or T-cell mediated immune suppression therapies, knowing that actually splenectomy might work faster, to be honest with you. When you do that splenectomy, you might see a platelet response faster, but you have the morbidity associated with a splenectomy. So oftentimes we're reaching for those T-cell mediated immune suppression types of therapies first. But, I think that was a really, really great overview and a great discussion. And now to finish off the show, I just want to talk about one more thing, just very minor. So now let's say we have a patient who's on eltrombopag. So they're in the second line setting of their ITP, and they come into the office complaining of arthralgias and just feeling like they're going to fall when they're on walks. How do we approach that situation?
This is also a tough case. Arthralgias and myalgias unfortunately are a part of the side effects that patients can see with TPO-RAs. In less severe cases, we can consider telling our patients to use things like acetaminophen as needed, because remember, in general, we're trying to avoid NSAIDs in our patients just because they're thrombocytopenic. In severe cases, like in this one where you're saying this man isn't able to walk anymore, you can consider switching to a different TPO-RA. This is also actually a real case that I had in my clinic. We switched from one TPO-RA to another, and after a week or two, all these symptoms got better. My patient's able to walk again. He's back to playing basketball and has no problem. So it doesn't really make sense. We don't know why it works, but it does. If this still fails, then at that point, I think that's the time to start switching to a different agent, because unfortunately, this is a chronic disease. We don't want to create more problems for our patients. And I always tell them, our goal is to try to get you to be able to enjoy your life again and not have you think about your platelets all the time.
I thought this was great. And we had one more case to go through. In the interest of time, I'm going to kind of just cut it brief here. The last case that we were going to go through was a patient who had seen frontline steroids, rituximab, splenectomy, and 2 different TPO mimetics, and they still have refractory disease. And we've talked about in our previous episodes the use of fostamatinib, that SYK inhibitor, and rilzabrutinib. Both are options for patients like this. Remember, the fostamatinib, the thing that we worry about is hypertension and potentially diarrheal side effects. We can always go down on the dose of that fostamatinib, so keep that in mind. Dose reductions can be effective. We also have rilzabrutinib, knowing that both of those agents should work within about 2 weeks. So if you're 2 to 3 weeks into that therapy, switch to the other one. Whichever one you choose, both are very reasonable options. We don't advocate for one versus the other.
And stay tuned, just because we already have a big toolkit for ITP doesn't mean that there isn't more stuff coming. So thinking about things like efgartigimod, daratumumab, sutimlimab, these are all things that are currently under investigation. So it's very likely that we're going to have even more tools down the road.
Guys, I think that was fantastic. I love this practical approach. I felt like we just had a fun little roundtable discussion about complicated ITP patients. And truthfully, these are the situations that give people a lot of anxiety and is very scary. So I'm glad we covered some of these common scenarios for our listeners. I think this wraps up a fantastic episode and another phenomenal series, this time talking all about ITP. Listeners, if you haven't listened to the first couple of episodes, be sure to do so. They're all on our website, on Spotify, on Apple. And I think that wraps up the series. So until next time, y'all, we'll see you all later.
See you later.
Peace.
This podcast was edited by Resonate Recordings.